We're going to have some time. We have about 20 minutes or so to have a nice group discussion and answer some questions from the audience out there. We've received a number of questions, which we're going to try to get to. And again, if we don't get to all the questions, I apologize. We'll try to follow up on the back end as well. But I just want to start out before we start answering questions, just really, for me personally, and the incredible proliferation of technology that we've seen over the last decade. I've been out of fellowship now for 15 years, and to see the incredible, not only in the pharmaceutical side, but the surgical side, and our ability to help maximize and balance really compliance and patient quality of life, as well as being aggressive, trying to get those pressures down at the same time. We didn't have that opportunity 15 years ago when I came out of fellowship. And now, with a lot of the new molecules, even recently with metarcidil, which is called Ropressa, or Rocklatan, which is a combination with latanoprost, or latanoprost and Buno, which is called Vyzulta. These are new molecules that actually work on the meshwork, the part of the eye that actually causes resistance. We can actually address the pathology, the area that's causing the pressure to go up as well. And then all the new surgical options that Sahar mentioned, safety being higher, we can address compliance if patients are having a hard time with drops. We can get those pressures down nicely as well. So I just want to say it's exciting for me as a provider to help offer these opportunities to patients to maximize their safety and compliance, as well as being aggressive early on. But with that said, we do have a lot of questions, and I want to ask the panelists here. The first question we see here as well, and I think I see this all the time, is dry eye. You know, we hear a lot about dry eye. I think it's become a new topic in ophthalmology and optometry in general. But how does it affect glaucoma? I mean, Sahar, Rania, you talk about drops and surgery. What are your thoughts on how dry eye affects glaucoma, and what can you do about it?
Thanks, Paul. I think I'll chime in here. Dry eye and glaucoma very much go hand in hand. A lot of the drops that we unfortunately start on our patients cause significant redness and dry eyes. So we are in a battle of trying to treat that while also treating their glaucoma. I think most patients will still vote to get lower pressure, and so that's why we keep them on these drops. But a lot of our discussions in the forums when we speak with the other doctors is how do we optimize the ocular surface to reduce that dryness? Maybe it's taking them off certain drops. Maybe it's just one drop that's a culprit. Maybe it's all of them. And then it's even more reason to go into a surgical situation for that patient. But it is certainly a chronic issue along with glaucoma. And I'm curious to see if Rania has any other tips for this.
Yeah, I agree with everything you said. And, one of the things I like my patients to know is even if we're maximizing treatment for one condition like glaucoma, it doesn't mean we can't maximize the vision in other ways. And so, you'll often see a patient with a cataract too that's affecting their vision, or dry eyes is a really good example. So, just like you, I try to optimize the ocular surface, because even if they have this visual field defect, if you optimize the ocular surface, they can often get better vision without even, having to do anything extra for the glaucoma. So I think that's really important to keep in their minds that, sometimes they go to these other doctors and they're being told, oh, there's nothing else I can do for you, right? But there is always something else you can do. And it's even something really simple like optimizing the ocular surface and fixing dry eye conditions.
I'm glad you guys brought that up, because it is really important to realize that there are very few other conditions in the eye that have as many associated symptoms as dry eye, right? Think about it: tearing, burning, fluctuating vision, pain, redness, all these symptoms. And so if you do have bad glaucoma, let's say, and you have lost a lot of your field of vision, you want to maximize the light entering the eye. And that's where we can try to address the surface as much as possible. Sometimes, as Sahar said, take you off some medications, give you a holiday, maybe do some drug delivery, a beam of light, SLT, and then put you back on drops if we have to. So again, I think we're trying to maximize the surface as much as possible now. We have tools that we never had before that can allow us that opportunity. So fantastic recommendations. Thank you guys as well. Another question we had here is a question on caffeine and does it affect pressures, and how do we have to limit the amount of caffeine, excuse me, that we use? And so, Alicia, what are your thoughts on caffeine and the ability for that to change pressures?
Yeah, so for me, I had a couple glaucoma patients that said, they came into the low vision clinic and they said, hey, I stopped drinking all coffee and now I have these terrible headaches because I think that the caffeine could be causing my recent increased IOP spike. And what I usually will tell to these patients is I'll always talk with their glaucoma specialist as well But if you've been having your 1 to 2 cups of coffee a day, the last 20 years, and now you stop them and it's causing awful headaches, I don't think stopping those 1 to 2 cups of caffeine a day are going to cause your glaucoma to be significantly worse. Now, excessive caffeine for many reasons, not just glaucoma, is not ideal. So having like 8 to 10 cups of coffee a day, or I had one patient that came in that was drinking like a huge extra large coffee 4 times a day. For many reasons in general health, as well as your eyes, I'd probably recommend cutting that back. But your standard 1 to 2 cups a day, if you've been doing it for years, I don't always tell patients needs to be stopped.
Oh, good question. Yeah, there's some studies that show caffeine actually doesn't, in fact, increase, actually lowers pressures in some cases. But general health, you're right. I have ADD in general. I'm always hyper. So me drinking more caffeine is not a good thing. Trust me in that one. But since I have Alicia, you right now is talking, tell me about computer screens. We just talked about dry eye, but are computer screens bad or good for when you have glaucoma?
So some patients with glaucoma can experience more glare or difficulty from computer screens in some small studies. But the computer screen is not making glaucoma worse. So that's what I always tell my patients. Now, with extended computer use, it can make dry eye worse because you tend to blink less often when you're staring at a computer for hours and hours. So some things that I'll recommend, because dry eye can be seen in up to like 60% of glaucoma patients. So what I'll tell patients is you can get these little timers downloaded from the internet for free. They remind you every 20 minutes, it'll beep. Just look 20 feet away for 20 seconds. Blink your eyes, stop the eye spasm from looking at the computer for so long, and keep up your good visual hygiene. Other things, a lot of patients will ask me about blue light blocking glasses for computers. They are always an option. I will say that the current studies do not show a huge benefit from them. So when patients go out and spend hundreds and hundreds of dollars on blue blocking glasses, there's no large scale study yet showing that that is definitely helping. But to patients that anecdotally are benefiting from them, there's no harm in using them. And many other tints, sometimes I'll trial a computer as well.
Right, yeah, the 20-20-20 rules help me a lot because I'm on the Zooms all day long. And even now, I'm like, oh my God, my eyes are getting dry. Oh no, I can't see. So thank you for that. I appreciate that. Just moving on, we have so many questions. I want to make sure I get to as many as possible. David and Sahar and Zaranya. So combined cataract and glaucoma, is that something that we're doing mostly now? Is that something that's, what are some of the options? I know you mentioned, Sahar, some options, but can you combine cataract and glaucoma surgeries? Is that commonplace now?
I think we're doing that more than ever before. It's interesting to see how things have changed in the last 20 years. When I graduated from residency, and now I'm aging myself, it was basically viewed that to combine the two meant one of them was going to fail, right? So either you're going to have astigmatism at the time of cataract surgery from the trab, or the cataract surgery was going to increase the failure rate of the trab. And now with MIGS and small incision cataract surgery, so through corneal incision. And again, when I was in residency, we were actually doing superior scleral tunnel incisions. So yes, things have changed. And now if there's somebody who's even on one drop for glaucoma and they've got cataracts, we should be thinking that this is an opportunity to treat this individual surgically with the safer, minimally invasive glaucoma surgeries, as well as some of the blood-related surgeries that are now available. And one of the reasons for that is what you mentioned, is getting these patients off these drops can improve dry eye and improve the quality of their vision. So that's my view.
Well, Sahar, you do a lot of glaucoma surgeries and MIGS procedures as well. And so let me ask you, what is the value? This is someone's on just one drop, they're tolerating the drop okay. Would you still do, let's say, a stent or something else at the time of cataract surgery to get them off that one medication? Is there a value just getting them off of one med?
Oh, absolutely. I combine glaucoma surgery with cataracts, and it's different for different patients. So if a patient is stable and on one drop, I will do, a stent or some kind of angle surgery at the time of cataract surgery. Some of these MIGS devices really can only be done with cataract surgery. So I want to optimize that time in the OR and really do as much as I can and with the lowest risk possible to get this patient off drops, get lower pressure, it is all about improving their situation. So the more, so the stents or the angle surgeries are great in the more mild to moderate cases. In the advanced cases, you certainly can combine glaucoma with a larger tube or a trab. I typically do those separately because I find that it's better, has better success for me. However, in the more mild to moderate, absolutely. I'm in there. I am going to do something to lower their pressure.
Yeah, I mean, Ronnie, I'd love to hear your thoughts. I mean, do you find yourself doing cataract surgery a little bit earlier than you used to? I mean, obviously, cataract surgery is safer now, and the earlier we take out the cataract, the quicker and safer it is for most patients. But do you find yourself now with glaucoma patients, you're saying, you know, let's consider cataract surgery earlier than you would maybe have waited earlier in the past?
Yeah, no, absolutely. I mean, we've always known that just removing the cataract, debulking, the eye a bit, always lowers the pressure by, my experience, 2 to 3 points. I don't know what you guys think, but it would be good to hear your opinion too. That in and of itself is already a help. And like we talked about before, sometimes the name of the game is to maximize the other stuff in the eye, even if you can't treat one disease like glaucoma as much as you have been. So I think that's really important. But then just like, you guys were saying, I almost think that it's, you're doing your patient a really big disservice, I think, almost if you don't think about doing a glaucoma procedure at the same time as cataract surgery. Because just like Sahar was saying, some of these devices are made to be used at the same time as cataract surgery. And it's not even about really the ocular surface at that point. It's giving the patient a way so that they are always controlled by a way to control their pressure, and it's not dependent on them remembering to take their drops. So, compliance, as we know, is an issue, and this is a really nice safeguard that we can add at the same time as cataract surgery relatively simply.
Yeah, I think even, David, you mentioned astigmatism. I think now we're actually treating astigmatism with cataract and glaucoma now. Before, because of trabeculectomy, we said, we're going to do so much. We're not sure what our outcomes are going to be like from a vision perspective. Now, because these MIGS procedures, these angle-based surgeries are more predictable and less traumatic, I think we are able to offer things like a toric lens. Are you guys offering astigmatism correcting lenses at the same time as well?
Oh, yeah, absolutely. Sorry, David.
Yeah.
It's the problem,
right? The premium channel. So, Sahar, do you offer premium lenses, like say, like premium that, or even let's say an extended depth of focus lens for certain glaucoma patients?
I do. I do actually. If the patient is mild to moderate and they don't have any central vision loss, I will offer them that. If they're advanced, or if they have central vision loss, or they have significant peripheral loss, I don't think that they will benefit from a premium lens. However, in the early stages, absolutely, because there is a very high chance that that patient will never get significant vision loss from their glaucoma. And while I'm in there, I really want to help them with their presbyopia or their reading and their distance. And sometimes I have patients that say, even if I get 10 years out of this lens and somehow later on get glaucoma, at least I got really good 10 years. And so I always do offer it in patients that qualify. And I tell them all the risks, the good, the bad, the ugly, and I let the patient make the decision. But again, you have to be able to offer that to the patients.
That's exciting. We're finally able, again, to improve quality of life for our glaucoma patients when we never had the opportunity before as well. So I think for me, it's a philosophical difference now. And many years ago, excuse me, I used to say, okay, I have a patient with cataract who happens to have a glaucoma. So I'll take care of the cataract, deal with the glaucoma later. But now that we have these options, I think of my patient as a glaucoma patient who happens to have a cataract. So I'm gonna do everything I can, if I'm in there for cataract surgery, take care of the glaucoma at the same time and maximize both as well. So thank you for those insights. I'm gonna move on to some other questions. I wanna get James involved. Sorry, James. Talking surgery all day long here, but you had some great points earlier about how to cope and the psychology behind what our patients are going through. What about exercise? And you mentioned a little bit about what you can do, but can you elaborate more on what exercises might be good for patients, not only from a safety, but also just from a psychological perspective?
Yeah, I mean, I think depending on kind of the level of low vision, it'll vary person to person. Obviously, if they can be mobile, definitely walking, things like that. Definitely, I think it was Nina or Tracy mentioned like the kind of lifting, actually working out in the gym, doing stuff on machines can be really safe for people with low vision, just because everything's there, and it's not like other things where you might have to be moving your body more in a confined space, but finding an open space too, where you can kind of do whatever doing different kind of exercise routines, whether it's calisthenics, free weights, things like that. I think pretty much most of them can be safe for people with low vision. I don't think there's too many, at least in my experience, I don't think there's really any that would be off limits, other than maybe like I wouldn't recommend somebody run in a big city unless they're going to like a track or something like that. But definitely want to be careful when it comes to like traffic and crossing streets and things like that. Um, so yeah.
I think it's good to get. I think getting out there, getting active as much as possible. I think psychologically speaking, I think it seems like the more my patients are active and can you continue some type of regimen, continue some type of activity that they can do every day, I think it just keeps themselves more stable and it feels like they're integrated in society more than being isolated. So and the psychology behind it and what you spoke about is so important. So thank you for all that as well. Quick for the panel, and anyone can answer these questions here. I love to answer two of them. One of them is, sleeping positions. There are certain studies that show glaucoma can be affected by pressure and blood flow. And do you find that there are sleeping positions that you tell patients not to, or to avoid rather? Anyone want to talk about that?
But it's a tough one because people tend to sleep a certain way, and if you tell them to sleep a different way, it disrupts their sleep. And so which one is really the most important. If we don't get good sleep, then that's bad for our health. But in general, I will tell, especially my patients who have vascular dysregulation, low tension glaucoma, if they can sleep or say pressure related issues other than in the eye, if they can sleep with the head of with their head elevated 20 to 30 degrees, that may be a benefit. If I have patients who have one eye that is significantly worse than the other in terms of their glaucoma, I will tell them not to sleep on that side. So if their glaucoma is worse on the right, I'll tell them to try to sleep on their left side. There may be some benefit there in terms of the pressure. But my experience in general is that people are so, they have a certain way that they sleep, and it's very difficult for them to get rest if they change that. Other experience there?
When I was in fellowship, we did a project, or I knew about the project we did at our institution, where they put a contact lens that measured pressure, and they found that patients who were sleeping on their eyes, so the pillow pressing on their eye, was actually increasing the pressure and was causing some problems and some potential worsening of vision for some of the more advanced patients. So, I'm not as worried in the mild patients, but in the advanced ones, we may want to consider educating them, because people don't know what they don't know, right? So I would say yes. So I would avoid sleeping on the side with pressure, so that you're not constantly pushing on the eye, because that is in itself causing the pressure to go up for 5 or 6 hours. We're doing all this stuff to try to lower the pressure, and then physically pushing on it could actually cause that. It's a small thing. Whether it may or may not affect them in the long term, we don't actually know, but I certainly would recommend it. But I agree, it's hard. It's hard to change someone's sleep pattern. If they like to sleep on their stomach, then they're going to get pressure on their eyes. But it's definitely worth letting them know about it.
Those are great points. We have a couple minutes left here, so I'm going to be rapid fire here. Even as a primary therapy, can you repeat it, everybody? Do you repeat it, and can you? Yes.
David, sorry, you cut out. What was the thing?
Sorry, can you repeat SLT, and do you repeat SLT?
And so that's a really interesting question. We know it can be repeated. I think in general we've taken the approach of performing SLT, and then when it fails, redoing it. There's an interesting study going on in Italy right now, in which they're just repeating SLT on a regular basis with a really low energy level. I think that's a really interesting option. We don't know the answer yet, whether that's the best way of doing it, but it's such a low risk treatment. My view is that, if I've got a patient who it's wearing off on, my first thought is to offer to repeat it.
Yes.
And another question I have real quick for everybody here, just for the sake of time. Is there a maximum number of drops one can take a day? This can be anybody's question. Do you have a max? Do you have a max that you say, okay, I'm done with drops? Or do you just kind of have a certain limit, then you add more? Or how does that work for you?
Well, you can add up to 4 different, maybe even 5 different bottles. And certainly there are patients that are on that if they need to be. I typically, once I start adding the 3rd bottle to a patient, I am thinking about surgery because we have found that it's not very useful after, you keep adding and adding, right? And it's not very useful for pressure lowering after the 3rd or 4th bottle that you put on there. In some patients, however, especially ones who don't want surgery or can't have surgery, sure, absolutely. We put on as many as we can to get to the optimal target pressure for them.
That's great. Absolutely. Changing our paradigm. We're not waiting until people have, poor compliance, and then we'll do something. After 2 or 3 bottles, it's hard to keep stable. Real quick here, I know I'm going pretty fast here. I want to make sure storing your bottles. Do you guys have any advice on storing them when they're walking, hiking, traveling? Any thoughts? Are you okay to keep them out?
I always tell patients just to keep everything really in the fridge, just because it's cooler when it hits the eye's surface. It doesn't burn as much. And then, being out walking or out and about, you don't have a choice a lot of times. But yeah, whenever you can, I tell them to cool them down in the fridge.
Yeah, that does. And they can tell they got in the eye too, which is kind of nice. You're absolutely right.
That's
Alicia, any thoughts on what over-the-counter medications they should avoid in terms of pills or even drops?
Yeah. So normally what I tell patients is if they're going to be taking like an over-the-counter artificial tear or something, make sure it's separated by 7 to 10 minutes from your glaucoma drop. Because oftentimes if you're putting in those over-the-counter drops and then your glaucoma medicines, not all of it gets in, some of it washes out because it's too much liquid going on the eye at a time. I also tell patients to be really careful about any like hydrocortisone cream or steroid cream near the eye. They sell that over the counter now, and patients will use it like if they get like an allergic reaction near their eyelid, but that can really spike your eye pressure. And so I always tell patients, definitely avoid that. Another thing I find is sometimes patients will start taking like Preservision or iVite when they have glaucoma because they see it on TV or they see it as an eye vitamin at the pharmacy. Those over-the-counter eye vitamins can be useful in certain types of macular degeneration. But Preservision for glaucoma isn't necessarily well studied or indicated. So you might be spending a lot of money on a vitamin over the counter that may not benefit your glaucoma specifically.
Yeah.
Well, thank you for that. Unfortunately, we have so many more questions, but not enough time. But we're going to try to get to them in the next Q&A session. Thank you, everybody, for the panel. Thank you for great presentations and all the questions from the audience.